So we have two good TROP2 ADCs in this setting. We can keep discussing, which is the better to use in the first line. Again, some have more mature survival data, cleaner data set, better response rate. But in the end, we still have two. How do you think about utilizing both of these? Now, putting HER2-directed ADC to the side. So we have both. Would you sequence these one after another? If you treated with Dato-DXd first, at some point, would you use, Sacituzumab, Govitecan? Or if in a patient you felt Sacituzumab, Govitecan is more appropriate based on the toxicity profile and preferences of the patient or whatever you're considering, would you subsequently treat with Dato-DXd?
I don't know.
Can you solve the big question in oncology right now on sequencing
like
right here and now?
Good plenary talk for ASCO when the results come out. I think that, first off, there are many active trials that are looking at sequencing right now. So we are going to have this answer in a clearer fashion, hopefully within the next year or so. We don't have many data on sequencing. We had actually a recent trial in ESMO Breast, the SATIN trial, very different patient population, HER2 positive, to the negative trial with a Trodelvy with Herceptin post in HER2. We also have data from the pan, tropion pan tumors. So the across I think pan cancer, and there was some data on some sequencing of ADCs. In general, and if you look at all these combined, it appears to be some efficacy on ADC sequencing, but the number and the mechanism of these differ by the different classes. I think there is also another point in which we don't even necessarily know what are the most impactful reasons for resistance to ADC1 before going into an ADC2. So you look at the classic HER2 targeted, in HER2, some would say it's the payload, active efflux, and some would say just the downregulation of the, target. You have similar discussion in the, in the TROP2 world. But to even make it more complicated, Trodelvy or Sacituzumab, for example, we know that it's TROP2 independent. Darovasertib is not necessarily dependent activity-wise on the ligand, on the TROP2 expression. So all of that collectively just paints a picture that we don't know necessarily how much activity to anticipate after progression on one ADC. And that would be even more important if we have, TROP1 directed resistance, like an upregulation of ABC bomb, there is efflux in the drug. So to answer your question, I don't know what the data will look like. I think it is a reasonable approach. At the end of the day, we will likely use some sort of a chemotherapy anyways. And we know ADCs have been historically outperforming chemotherapy at every step of the way. Some physicians are advocating a sandwich approach, do an ADC, give some chemo break, maybe a different mechanism, not a TROP1 directed a mechanism of action, and then go back to another ADC. That's also a possibility. I think that this was going to be a very important question. I think in reality, people will sequence ADCs, and we're going to actually have some real-world evidence before we see it in a randomized trial fashion, to be honest, because they are much more tolerable on average compared to chemotherapy. So that's something that I believe is going to happen. One point on ADC sequencing that is also important to consider is the role of immunotherapy in these settings. And if somebody received immunotherapy in the first line setting, do we continue immunotherapy in second line setting? There are trials that are also asking this, and one of the TBCRC trials, 047, is looking at different combinations with Sacituzumab, Govitecan. So again, it's a very active field. I don't think there's any clear data on that topic, but I think that from a practical standpoint, patients will ask about it, and we might end up having to have some of that in the real-time setting.